So we're going to talk about surgery. And just for my students so that they understand, this is to supplement what you have in the resources that you can look at, like your ebook or your hard copy of your book that you have. This is from another resource, but this is information you should know. So I'm going to share it with you. I've broken down this into three parts. This part, which is an introductory part, we'll do a pre-op and intra-op piece together, and then we will do a post-op piece. And that should bring it together for surgery. When we're looking at surgery, one of the biggest things that we need to understand is as nurses, we are going to come across patients that either are in same-day surgery, surgical with conscious sedation patients in the clinics, and then actual major surgeries that are done within the hospitals under general anesthesia. So you might have a patient on the floor in the office, you never know, but you're going to come across these patients. So it's so important that you at least know the foundation of what it takes as a nurse dealing and involved with any surgical patient, pre, intra, and post. So let's get started. So if you look at this, I'm not going to read it to you. This is just telling you what we're looking for and looking at. We're going to identify the types of patients that are at risk for surgical complications. As you learn disease processes through adult med-surg, you're going to understand that patients with diabetes or chronic illnesses are at more risk for infection and dehiscence of wounds just due to poor healing. Advanced age with inactivity, they are prone and prevalent to pneumonia, hypostatic pneumonia, just because they're not moving or they're not taking deep breaths. Obesity, extremely heavy patients don't breathe as well, they don't breathe as deeply, and they're at a high risk for that hypostatic pneumonia. And then in general, people, anesthesia, there is no rhyme or reason. We understand it to the point that we can understand it, if that makes sense. But there are a lot of people that can actually die under anesthesia or in surgery. Now, we know that people are at risk just because surgery really does try the body. It's hard on the body. So it's hard on the heart. It's hard on the kidneys because your body's being cut on. It's being, trauma's being introduced to the body, and that creates this. So everybody is at a risk and there's an unknown. And before they go into surgery, we should always have the anesthesiologist discuss this with the patient so that they are aware of their risks prior to going under. We'll go in a little bit deeper with this as we move along. So the theory objectives are present here. I'm not going to read through those for you. You can take a look at them. Your clinical practice objectives, always, if you look at number 1, perform a thorough nursing assessment for the pre-op patient. We definitely need that. You are only as good as your assessment. I say that to my nursing students all the time. You're only as good as your assessment. If you don't assess well, if you're not observant, if you're not picking up on cues and looking and constantly seeking and observing your patient, touching your patient, listening to your patient, then you're not going to be a very good nurse. If you're in tune and on top of, you will be ahead of the game and usually provide great care for your patient. So there's different types of surgery. So if you look at the first one, we're looking at diagnostic, and it says it there. It's to determine the origin and cause of the disorder or cell type for cancer. Diagnostic surgeries, examples of those are breast biopsies, exploratory laparotomies, and arthroscopies. And so those are different ones where we're looking and taking tissues and trying to figure out what's going on. Curatives is to resolve a health problem by repairing or removing the cause. So examples of that is a a cholecystectomy, we're going to remove the gallbladder. A mastectomy, we're going to remove the breast that has cancer in it. A hysterectomy, we're going to remove those female reproductive organs so that we can hopefully cure whatever's going on. If it's a cancer or if it's fibroids or if they're just having excessive bleeding for whatever reason, they can actually, it's considered a curative a curative surgery. Restorative, this is to improve the patient's function and ability. A total knee replacement, a total hip replacement, finger reimplantation. We're going to put another finger on, put the finger back on. That's restorative. We want to make it go back to where it was or how it is and let it function at a normally. So that's why we'll replace the knee, and these people will hopefully walk and be in better shape than they were with the knee that would not function for them, their original knee. The next type of surgery is palliative. It relieves the symptoms of a disease process but does not cure. So if that's the case, we're looking at a colostomy, right? We're going to, if you have Crohn's disease and your GI tract is just totally scarred and you're having all of these issues, they can remove the bowel, they can remove the intestines and parts and pieces and create a colostomy that will hopefully relieve the symptoms or the issues that are going on. Tumor debulking, they can go in and get rid of. An ileostomy is another example. So these are considered palliative surgeries. And then, of course, we have cosmetic surgery, and it's primarily to alter or enhance personal appearance. That's your liposuctions, but that's also revision of scars. You might have someone that was mauled by a dog or burned, and so those are cosmetic. They'll go in and they'll do revision of those scars. They'll work on removing scars or making the patient their appearance to be back to more of its normal appearance to hopefully rid them of the scars. Rhinoplasty, nose jobs. Those are all examples of cosmetic surgeries, and there's tons out there, guys. And they're being done every day. So it's something to think about. But when you're thinking cosmetic or you hear cosmetic surgery, don't always think of the Hollywood clan or anybody else that are getting their, facelifts and stuff like that. This does actually deal with scars. We had a small child one time that had a dog bite, and unfortunately it grabbed her cheek of her face and in the ER, and one of the things the ER doc insisted on was that we get a plastic surgeon in to work to sew her up so that it would hopefully prevent her from having a horrible scar. But in the meantime, once the plastic surgeon came in, he sewed her up, but he did say to the family that down the road she will need to have cosmetic surgery. She can, if they would like, to help, make that scar even better. Or lasers. They're using lasers now to help with some of that. But we're looking at surgery, not laser. But I guess it's laser surgery where we laser off things. Those are also very present. So urgencies of surgery, we have elective, urgent, or emergent. They're pretty self-explanatory. If it's elective, it's planned for correction or a non-acute problem. That's your cataract removals, hernia repairs. If you've planned it and you can go in, total joint replacement, it's an elective. It's not emergent or urgent. Urgent, it requires prompt intervention. It may be life-threatening if the treatment is delayed more than 24 to 48 hours. So you have a day or two, but they're going to have to go, right? So that is like if there's an intestinal obstruction, bladder obstruction, kidney or your kidney stones, and the reason why it can be is in a day or two, you're occluding or backing up urine. Bone fractures, we can have people with broken arms and they can wait and then they can go into surgery and have things placed. Where it becomes emergent, if it's life threatening, and if that goes back to ABCs. So if you have a fracture and it's occluding a pulse, or it's severed through something, they're going to have to go immediately because that's considered emergent because they're not perfusing, they're not going to keep their limb. But if it is a fracture, they've got a pulse to the extremity, you immobilize, and then in a day or two, they can go and have surgery at that point, and that's considered urgent. Eye injuries and acute cholecystitis is also considered urgent surgery. They don't have to necessarily go immediately. But emergent, like I said, is life-threatening. That is any kind of trauma that is life-threatening, such as gunshot or stab wounds, any severe bleeding, of course, because they're going to bleed out. Abdominal aortic aneurysms are in that. Compound fractures. A compound fracture is a fracture that's come out through the skin, and those need to be put back in by the surgeon, not by us or the patients. And an appendectomy is considered emergent because we don't want it to rupture. One of our exemplars is appendicitis, and the cure for an appendicitis is an appendectomy. We're going to go in and remove the appendix. And we want to do that before it ruptures, because if it ruptures, it's going to spew infection all throughout that cavity there and cause the patient to become septic. So those are considered emergent surgeries. So we have degrees of risk of surgery. We have minor or major risks. Procedure without significant risk are often done with local anesthesia. They're considered minor. And so those include incision and drainage INDs, that's what they're called. Implantation of venous access devices. So if we're going to go in and implant a port on a patient, that's a minor. Muscle biopsies are considered minor, but major are procedures of greater risk, usually longer or more extensive than a minor procedure. They give a few examples of that. It would be mitral valve replacement, pancreas transplant, lymph node dissection. Now, when you're looking at these minor and major surgeries, there's thousands, guys. You can break it down, but think about it. If it's something very minor, it's considered, if it's something that's without significant risk, grandma can go in and have this done. A child can go in and have this done. An adult can, any adult without whatever's going on. And it's usually under local anesthesia. We're not going to put them under general where they're intubated. Major surgeries, they're going to go under general anesthesia and be intubated. There is a greater risk. They're at a greater risk, and it takes usually longer or more extensive. They're going to have to, open up and move things. Open heart surgery. They're going to put the heart on a bypass machine and actually work on the muscle of the heart or replacing the valves of the heart. Those are major surgeries. So just remember that. Just because I give you some examples, it doesn't mean it's the end all. These are the only. You've got to start to think of, well, that would be minor or major. But there's some minor surgeries that start out minor and things can go wrong. And if that's the case, then it becomes major surgery, and that's where they're rolled in emergently. Childbirth is a good example of that. If we're going in, we're actually doing some minor things, localizing pain, trying to deliver a child, and then there's distress on the baby or distress on the mother, then we're going into major surgery and get this child out. So those are the thoughts. So we have simple or we have radical surgeries. So simple surgeries are only the most overtly affected areas are involved in the surgery. So that is usually like a simple or partial mastectomy. We're going to just take a part of it. We're looking right at that little area that's got the cancer. We're going to cut it out, and that's it. It's a simple surgery. There's not more involvement. It's just right there, and you're getting what you need. Then there's radical surgery, which is extensive surgery beyond the area obviously involved, is directed at finding a root cause. So this is where we have a radical hysterectomy. We're going to take everything out. We're not really sure what's going on, but we're going to really get in there and do what we need to do. And then we have, actually, to add to that, a minimally invasive surgery. So that's where we can do an arthroscopy or a tubal ligation where they can go in and just tie your tubes. We're seeing more of this where they're not having to cut you wide open. We're seeing it more with the scopes. So it's usually surgery that's performed on a body cavity or area with one or more endoscopes. It can correct problems, remove organs, take biopsies. This is where you'll see it's a great thing happening. What do you think when we talk about that? What do you think we're doing or helping with? The biggest thing with surgery is infection. It is our biggest concern. So if that's the case, if we don't have to cut a patient's abdomen wide open, but we can make 5 little incisions and put scopes in, blow them up with CO2, and then go in there and use scopes to go in and just get right to the where we need to be and remove or do whatever we need to do, and then come back out, seal those little incisions, we have decreased the risk of infection for that individual by leaps and bounds. So the way that we're doing this now, using different machines and technology to get in there and actually do this, is fabulous. We see it a lot with they can do hysterectomies this way. They can go up through the vagina and actually do a total hysterectomy, so they're not having to cut you from one side to the other and open that area. We do tubal ligations that way. We remove gallbladders that way. We deal with bladder surgery and different things that way. So there's definitely medicine is moving in that direction. And what's great about it, it's also a very precise technique. So all your kids out there playing the game systems, they might end up being great surgeons one day. Because if you ever watch this surgery, it's just fascinating. They're looking at and doing it through an actual machine, looking at you on it, and they're moving and manipulating these scopes. So it's very interesting and exciting, and hope for our future. So, like I was saying, trends in surgery, technological advances in surgery, we're looking at the robotics, like what I talked about. They're huge and they're great. They allow magnification up to 12 times than the normal vision with robotics. So they can really see what they're doing instead of in there like the old ways and cutting and blood and things and having to suction this and that. And you still have to have that. But to magnify something like that, how awesome. Remote controlled instruments are inserted through these incisions. So the advantage for the robot is it has rock steady hands. There's no slip of the hand or no issue of an actual, oh, and I accidentally cut this or something goes wrong there. The robot will stay steady and do exactly what it's to do. Small surgical wounds, of course, will heal faster for these patients. So this is just awesome. And they're training surgeons, I mean, every day to start to use. And the robotics piece of surgery has grown leaps and bounds over the past 20 years. But I'm going to tell you, in the next 20, it will grow even further. And so it's an exciting time. Autologous blood for transfusion. That's where if you know you're going to have surgery, you can go and give your own blood to be given back to you. We can also collect blood. I talked about this with chest tubes with some students in lab, is that the Oasis atriums, there is a bag, a like kind of structured bag that can come with them. And if you have a patient that's putting out a lot of blood post-op, you can actually collect their blood in this little bag, And what happens is you connect it to their chest tube and you connect it to the atrium. So it's not going to go, it'll have that water seal. So you're going to collect, you're still doing what the chest tube should do, but the blood is going to get trapped into that bag. And what happens is you take that bag once it's full and you flip it up and you give the patient's blood back to them. And you can give it as quickly, and they should not have any kind of transfusion reaction because it's their own blood, which makes it great. There's also bloodless surgery. And if you've never heard of that, is that they're bloodless surgery usually is a combination of techniques to minimize blood loss and maximize blood volume and function. So we give them epoetin alpha or Epigen or Procrit. Please put that in your nursing notes for my section. You need to know epoetin alpha or Epigen Procrit. It is given before surgery, and what it does is it stimulates the red blood cell production. So we're going to produce more red blood cells. So if they do have a blood loss, they're going to produce more and hopefully replace quickly. It can be given before or during surgery. Before or during or after surgery, we can give epoetin. We also give Epigen to other patients. We give it a lot in the renal world, so you'll learn it as we go along with other things that are going on with patients. But for right now, I want you to know what it is and why we give it. And it's to produce more red blood cells. And we all know what red blood cells do. One, we need circulating volume to live. You got to have blood to live, and you got to have X amount in the body system to maintain homeostasis. The other thing we know about a red blood cells is oxygen carrying capacity. It is what our little truck is that picks up oxygen and carries it around to our body, and it's so necessary that we have it. So if we want to go with a bloodless surgery, we can actually give that medicine, and that can help in that way. They also, during bloodless surgery, the surgeon can request to have induced hypotension or hypothermia, and this will decrease the oxygen demand. So these are things that we do to have a bloodless surgery. The other thing we do is we can hemodilute, in which several units of the patient's blood are removed and replaced with crystalloids or colloids to expand the volume. But hemodilution decreases blood viscosity and improves oxygen transport, and if bleeding occurs, it helps if bleeding occurs during the surgery. It minimizes the loss of the red blood cells. So what we've done is we take the red blood out, we go ahead because you got to have the volume, and we give them those crystalloids or colloids, and it dilutes what's circulating at that point. And because of that hemodilution, it's going to decrease the demand of oxygen. So it minimizes the loss of the red blood cells too. So if you bleed out from this, you've got blood, your own blood to put back in. So they just put it back and give it back to them. Now, always remember we have cultural considerations when we're talking about things. And this is something I want you to hone in on also, because Jehovah's Witnesses, they do not accept blood transfusions from another person because of their religious beliefs. We as nurses, no matter the circumstance, we need to honor and respect people's culture or their choices. And sometimes that's difficult for us because I'm going to be honest with you. I've been in an ER trauma situation, and it was a small child. And the parents said, no, it is against our belief system for them to receive a blood transfusion. And the child did pass away. And that's difficult because for me, I'm thinking just one unit of blood could have saved them. But I have to step back and remove myself from this and think about it in the way if it were me and it was what I wanted for my child or what I wanted for myself or my loved one. And I would want that respect and I would want that consideration. And so you have to remove your personal beliefs from this to stand in the shoes of the individual and what's going on. Because if you believe in something, you believe in it, and you would want me to respect that and consider be considerate to your choices. That wraps it up, just the basic kind of introduction to surgery. There's a lot of key points in this, looking at the robotics piece, looking at the different kinds of surgery, and understanding, because if you hear a physician say we're going to do a minor surgery, you need to understand what a minor surgery is. And so you can be the advocate for your patient so that you can stand there and say to them, when they're told all of these things, they're in shock, they're scared, they don't understand, and you're able to, in layman's terms, explain what's going to go on or what's happening or what's being said. I hope this helps.